Welcome back to the second of 3 videos of Lecture 3 in the Hematology series. Last video we ended on the intrinsic pathway and the formation of the secondary platelet plug, where the fibrin monomers formed a scaffolding over the platelets to form a strong structure. So let's quickly review the extrinsic pathway. So extrinsic pathway is initiated with tissue injury. Tissue factor is released. Tissue factor activates factor 7. Factor 7 also activates 9 and 10. When we want to look at the extrinsic pathway, we look at the PT. Joe likens the PT like PO, anything you can take by mouth. Coumadin, warfarin. Don't get confused, aspirin is not part of that. That affects the platelets. If you have a patient who has abnormal bleeding with dental extractions, a traumatic knee effusion, what do you think of? What's most common in 80% of the cases? Males greater than females. And the PTT, the intrinsic pathway, is affected. It's hemophilia A. So hemophilia A affects factor 8. And the treatment is cryoprecipitate, factor 8, and desmopressin. So it's the most common. You can have a traumatic knee infusion. And when we talk about hemophilia B, it's not as common, only 15% of the cases. Factor 9 is affected. You can have joint involvement. And that's what differentiates hemophilia A and B from C. C, rarely do you, if at all, do you see any type of joint involvement. So along with hemophilia A and B, PTT is prolonged. There's no normal bleeding time because platelets aren't affected. So hemophilia A affects 8, hemophilia B affects 9. With hemophilia B, you can have joint involvement, muscle, CNS, GI, genitourinary, and pulmonary system involvement. Now, hemophilia C affects factor 11, and it affects Jews who are of Ashkenazi descent, and like I said, it could be distinguished from A and B by joint involvement. And you do have a prolonged PTT, and bleeding time is normal, and the treatment is fresh frozen plasma. An important note to make that Joe emphasizes that approximately 50% of hemophilia A or hemophilia B are now HIV positive because prior to 1985 the pooled natural blood product was not screened for it adequately. Okay, now let's look at those factors that are dependent on vitamin K. So in order for the liver to produce some of these factors, vitamin K must be available. So an easy way to remember this is with the acronym SNOT, SN0T. So S stands for 7, N stands for 9, 0 would stand for the 0 and 10, and 2 is another name for prothrombin. So I circled those factors in green, and if you notice, both the extrinsic and the intrinsic pathways are affected by this. Okay, so both the PT and the PTT will be prolonged when vitamin K is brought into the picture. And when you want to look at preventing things like DVT, PEs, you'll use both warfarin, heparin, and Coumadin, because you want to prevent the PT and PTT, meaning the extrinsic and intrinsic pathway, from cascading out of control. You're going to look at the PT, the PTT, or the combination, which encompasses the INR, which we spoke about having a range of 2 to 3. So I wanted to review a few of the tests that are done. I used to just memorize these names and really never understood what they did, but they're pretty simple if you're able to visualize it. So the Direct Coombs test is when an antibody is directly attached to a red blood cell. Okay, so it's attached to the red blood cell. And what happens is you draw the patient's blood, you're looking for that antibody connected to the red blood cell. It's washed in what's called a Coombs reagent. It's a anti-human antibody, and what that does, if these antibodies are attached, it'll cause them to clump or agglutinate, and they'll cause them to clump, and you'll be able to see them in a test tube. So what we're looking for are autoimmune diseases, congenital diseases, drug-induced hemolytic anemias. So that's caused by IgGs being bound to red blood cells, and what happens is a complement comes along and takes care of those. They're lysed or by macrophages, or they're destroyed. So that's what happens in autoimmune hemolytic anemia. So your own body produces these IgG antibodies, and they attach to the red blood cells. They're marked to be taken out by our immune system. So with the indirect Coombs test, we're looking for antibodies that might be in the serum. So these antibodies can attack red blood cells, but are not attached to red blood cells. So the indirect Coombs test is most commonly done to find out if antibodies in a recipient's or donor's blood is present before a transfusion. So what happens is we draw the recipient's serum, we put the donor's blood into the serum, we wait, and we are then adding the Coombs reagent again, and if there have been IgG antibodies that have adhered to the red blood cell, they will clump again, and they will cause agglutination. So for example, in pregnancy, if during the indirect Coombs test there is found to be an RH factor incompatibility, RhoGAM, an IgG, is given to an Rh negative mother to prevent exposure to the Rh positive blood, to prevent erythroblast fetalis in the subsequent pregnancies, a fatal hemolytic disease of the newborn. So it's given at 28 to 32 weeks and given within 72 hours after delivery. Abdominal trauma with vaginal bleeding is another indication to give this the RhoGAM. So this is an image of the soft palate and the oral mucosa. So what do you think of when you see this? Now these are already pointed out as petechiae, purpura, ecchymosis. Petechiae is visible in small superficial vasculature like the oral mucosa. The question is the mucosa the only place this is occurring? The answer is no. It is occurring in deeper vasculature, but you just can't see it because it's covered up by multiple tissue layers. So you need to go to hunt to find out why. So keep this in mind as we discuss other disease processes. So if I see petechiae, I know it's a problem in the circulation that is leaking. I can see superficial small vessels, and these capillaries are leaking. So the platelets are responsible for the correction of this problem, and the intrinsic pathway. So are the platelets failing? Do I have a problem with the formation versus destruction? Do I have a problem with the coagulation factors? Do I have a problem with the bone marrow, drug complications, vitamin K deficiencies? Those are some of the things I have to think of. And the purpura is greater than 3 centimeters. That's about 2/3 of an inch. Ecchymosis is closer to a hematoma. It's the pooling of blood. So let's quickly review the components shared in the previous lectures. So as we discussed before, we can use the analogy of a train and train cars in describing the function of red blood cells and their carrying capacity. Their job is to carry oxygen and other nutrients to cells for their function, and to dispose of CO2, metabolic waste, and urea. So we can think of the red blood cells, I like to think of them as the wheels on a train car. Their shape is important in being able to move the train along. Vitamin B12 and folic acid, their nutritional requirements to form the structure for a red blood cell to have the correct function and carrying capacity. The hemoglobin, their structure is very important in determining the carrying capacity of those red blood cells. The heart, stomach, liver, kidneys, they all play kind of a role in either providing nutrients or disposing of waste or producing new red blood cells. As we said before, the plasma, the blood, if you're able to spin it down, 55% is plasma, 45% is formed elements, which include red blood cells. The hematocrit is the number of red blood cells that are present in those formed elements. The percentage is usually 40%. We use that in determining the function of red blood cells. Hemoglobin is usually 16 grams per deciliter, and most are what are called hemoglobin A1, 98% of that type, and we'll talk about when hemoglobin causes problems like in sickle cell disease. So when we order a CBC with manual differential, what we'll do is we'll look at a blood smear. We'll take a sample of the blood and look at it underneath a microscope. Typically what we can see are red blood cells. We can look at their shape, their potential size compared to other cells on the smear, their color, which determines usually how much hemoglobin they have. We can look at pathologies. When we look at ratios, we should see about 1,000 red blood cells compared to 1 white blood cell. We talked about white blood cells in the other lecture, so you can review that in the other lecture. There's about 1 platelet per 20 red blood cells, and like we said, the lifespan of red blood cells is about 120 days. A mature red blood cell could be differentiated from a reticulocyte, because a reticulocyte is a newly formed red blood cell. It can be stained, and what you can see are the organelles within the reticulocyte. So when we talk about erythrocyte indices or red cell morphology, what we're looking at is the red blood cell count, shape, color. We're trying to determine if there's a deficiency in the function of the red blood cell. Remember, we've said this before, any cell in the body is no more than a 2-cell distance away from a capillary. Some cells, such as neurons, require a lot more energy and disposal of waste because they're a lot more metabolically active than, let's say, some skin cells. Anemia is when hemoglobin in the blood is too low to fulfill oxygen demands. Remember, liquid is a poor carrier of oxygen, so we need hemoglobin bound in red blood cells to carry enough oxygen to meet the demands of our tissue. So when we talk about MCV, or mean cellular volume, sometimes it's referred as mean corpuscular volume, we're looking at the average red blood cell size. We say volume because I'll tell you in a minute how it's measured. So when you have a normal cell, it's 80 to 100, it's called normalcytic. When it's too small, it's called microcytic, and when it's too large, it's called macrocytic. So if we had to measure the average size of a red blood cell, we're limited to our ability to measure something on average of 7 microns, something smaller than our human eye can detect. So remember, you can count the number by a machine. So what we do is we centrifuge down and get the red blood cells, and then we multiply the volume of the blood that we get by the proportion of the blood that is cellular. Remember, that was the hematocrit. It's on average 40%. And then we divide it by that product by the number of erythrocytes, and that gives us the mean corpuscular volume, or the mean cell volume, and we can tell the average size of the red blood cells. Then we look at what's called the mean corpuscular hemoglobin concentration, otherwise known as MCHC or MCH. When we look at a red blood cell, the hemoglobin gives off a color. The color can tell us how much hemoglobin is contained in the red blood cell. So we look at the percentage by weight, or the average hemoglobin concentration per red blood cell. So if you look at a normal concentration, we call it normal chromic. Chromic means color. If the central power is greater than 50%, we call it hypochromic. If it's greater, hyperchromic, and I don't have one of those cells on there. I do have, however, what's called a target cell. So that's where the hemoglobin is accumulating in the center of the cell, or sometimes you see what's called basophilic stippling, and that's seen with lead poisoning. So if you hear target cell, and basophilic stippling, think lead poisoning. So most of the circulating lead is bound to red blood cells, and we'll talk about a little more about this in a minute. With only a small fraction in the plasma, if the levels start to increase, they say more than 60 micrograms per deciliter, the red cell binding is saturated and the plasma fraction starts to increase. So basophilic stippling occurs, in which the ribosomes are taking up the lead and they're seen on a blood smear. Alright, let's quickly talk about anemias, but it is heavily tested on in the hematological sections of the PANCE or PANRAY. So if we use our red blood cells in the analogy as being a train and train cars, it's the inability of this train and train cars to deliver enough oxygen to meet demands, the tissue demands, the cell demands, the organ demands. Whether those demands increase or our capabilities decrease, there's a mismatch. So let's keep in mind the morphology and indices as we discussed in the previous slides, as it is a method for categorizing anemias and other hematological disorders. So the first one we want to talk about is sickle cell disorder. So as you can see on peripheral smear, you might see a sickled cell. It's categorized underneath a normal chromic, normocytic anemia. It is a hemolytic anemia, and the reason why is because the indirect levels are increased, and there is an increased chance, as Joe described, an increased chance of having gallstones. So the problem is with a hemoglobin S being produced instead of the A like normal people do, and you would diagnose it with electrophoresis. So there's a genetic variant where the hemoglobin S is created. It causes an abnormal crystallization of the cell membrane. The cell becomes fragile, and the lifespan for a sickle cell is around 20 days. You can see that bumping around trying to go through capillaries and causing damage and becoming lysed. Another hemolytic anemia, it's also categorized as normal chromic, normocytic. It's G6PD. Heinz bodies, analogy that Joe used. Heinz body is a red blood cells where you see that there have been some denatured hemoglobin in the center of that. And you can remember Heinz bodies as Heinz ketchup, fava beans. We'll discuss that in a second with G6PD. So all cells are exposed to oxidation, and the only way that red blood cells have to protect themselves is through this G6PD, or this glucose 6-phosphate dehydrogenase, to protect itself. This becomes abnormal, the cells become more fragile, and they don't live as long because they're not able to protect themselves from oxidation. So some things that there's a Mediterranean variant of G6PD that's precipitated by fava beans. So if you see fava beans, you know what it is. And these can also be precipitated by oxidant drugs such as Bactrim, Septrim, microdantin, antimicrobials, and no treatment is necessary. So the next one, the thalassemia that we want to talk about, is a problem. It's categorized as microcytic hypochromic because it's a problem with the hemoglobin rate of production. There's two types. There's a major form, which is also called Cooley's or beta thalassemia, and there's a minor form. This can occur particularly in Italians and Greeks. The major form, also known as Cooley's anemia or beta thalassemia, is more common in families who intermarry. It also is found in other parts of the globe, like North Africa, in Southern Europe, in the Middle East also. So you can see severe anemia in these kids with hemoglobin levels from 3 to 7. And if it goes untreated, you can have problems like massive hepatosplenomegaly, severe growth retardations, bone deformities. So the key note on this one is that thalassemia should be considered in any child with hypochromic microcytic anemia that does not respond to iron supplementation. So if they're not responding to iron supplementation, what you want to do is you want to do a hemoglobin electrophoresis, and you'll see elevated levels of hemoglobin A2 and F. The continuation of this lecture can be found in the next video, video 3 of 3, in the third lecture in the series of hematology review for the PANTS or PANRAY.